how many of you are ever shown Florence Nightingale's picture when they're teaching statistics? Is she ever given credit as a statistician? Yes? Are you a statistician, or how do you associate statistics and Florence Nightingale? Okay. Anybody knows? So she doesn't come in a math class. We normally see her as a nurse. So let me tell you why. The reason why I put up Florence Nightingale's picture, so just to give a background, I work largely in improving quality of care. Actually, even before going into this slide, if I had to ask a question, if we talk about quality of healthcare delivered, what are the few key things that will come to your mind that you would expect when you go to a hospital? Sorry? Hygiene, great, absolutely. What else? Well-trained doctors and staff. Yes, no waiting times. How efficient the system works. Anything else? Transparency. Do you think our hospitals are transparent? Right from the healthcare delivered to the billing. I'm getting recorded, so I can't speak too much. Okay. What else? The quality of the infrastructure, the equipment available, the HR present. So you are looking for quality in input, you're looking for quality in some of the processes of care in terms of how clean it is, how efficient the system is running. Anything else? Okay, that's still an input issue. How many doctors for how many nurses? Very important. I mean, doctors to patient, nurses to patient, very important. So we talked about structure, we talked about process. Anything else? Improvement in how the staff is working. So that's service delivery. Anything else? The most important thing, that's the outcome, right? That's the most important thing. I mean, you want to know how many patients got better, how many patients got a complication because they came to the hospital. What was the actual outcome of the patient? Do you know, if you are in Delhi or any of the other metro hospitals and you go to a hospital, do you have any idea, out of all the things that you mentioned in terms of structure, process and outcome, there's transparency in which out of the three? Structure is visible. You can see how many doctors and nurses are there. Even process, to a certain extent, you can see how the care is being delivered in terms of your waiting times, and you can see how much transparency do we have in our outcomes. So we agree that there is a problem in terms of all outcomes in hospitals. There is a lot of variation in between healthcare practices, and there's a lot of opaqueness. So when you go to buy a car, or now you have all these travel portals, and you can compare in between the prices, what is giving you the best option. When you're buying a car, you get a whole lot of quality dimensions in terms of speed, and I do not know much about cars, but you can compare. But when you're choosing between A hospital and B hospital, it's largely word of mouth. That one person went there, became better, that particular doctor is good. We do not have enough information as a consumer to really decide on quality of the care delivered. In India, there's not even too many questions asked, because when I asked you about quality, your first question was about cleanliness and how many doctors are there. We are not even questioning the outcome so much, because it's a very hierarchical society. Though in some of the developed nations, there are more questioning asked about increased transparency. Before I even show you these slides, I'll just maybe mention 2 or 3 things. I think as a doctor, it becomes easier to see the kind of adverse events that are happening, which as a lay person walking into the hospital, one might not. And I have had a lot of personal experiences where I've had somebody as a doctor, I've experienced adverse event, and I have stories to tell about that. Something which might have happened on my duty because of X, Y, and Z reasons with somebody else. And also, as a family member, when I've seen it happening to some of my own relatives. I think, just a small example, my grandmother was hospitalized, she's no more, about 3 years back, and admitted to one of the Delhi hospitals. There were n number of problems, just telling you one key problem. So she was admitted with a hip fracture. She got operated, she went back, she got a post-op complication, and then she was readmitted. And she got readmitted with a surgical problem. Basically, she had infection and it was mimicking a surgical problem, but she had a distended abdomen. So we wanted to shift her to a ultrasound room, and they also wanted to shift her and get a CT scan done. One small key key thing that I will mention is that she got shifted to CT room and I was not there at that time in the ER. So when I reached the CT room, my first question to the attendant was, she's got a fracture. Do you know which side it is? When you picked her up, were you careful? Nobody knew. It's not part of a protocol. The assessment is not done. It's not part of the process on how we manage or give handover to patients. It's a very small aspect of telling. She had n number of complications, and I'm not getting into the details of that. A second example I'll mention with one of my aunts who got admitted to a hospital. She was very obese. She got admitted with difficulty breathing. So she's like 55, difficulty breathing. Probably it's going to be a cardiac problem. That's the way the thinking of the doctor went. He admitted her, and she was admitted overnight. So the next day, it was a Sunday, so it was a weekend. When I saw her in the afternoon, she was very breathless, and she was on like 8 liters of oxygen, which is a lot of oxygen that she was getting. And no other medications had been started, and they said, we are waiting for the cardiologist to come, and he'll do an angiography, and we'll take her and have an angioplasty done. We think it's a cardiac problem. I said, but just see the amount of oxygen she's requiring. If she's got a cardiac problem, why would she need? Her ECG is normal. No, we did a blood gas yesterday. The normal range which we see in blood gas, in addition to oxygen level, we see carbon dioxide level. So it should be between 35 to 45. So it was around 48, 50 for her that time. On the high end, but it was not very high. So but that was done yesterday. She said, no, it's okay. It was a little bit rude also that, being a doctor, why are you asking so many questions? I'm in charge of the ICU. This, please go from here. A kind of an attitude like that. 2 hours later, the cardiologist came in, and by that time, she had actually stopped responding much. So my uncle who was there for the rounds asked, he said, she's not even telling her name. Can you please have a look at her? He took off her mask, he called out to her, and she didn't respond. And then they panicked. The diagnosis was completely wrong. They did a blood gas. Her PCO2 had now reached 110. That's a direct indication to be on a ventilator. She actually was very obese. She was having problems with what we call as sleep apnea, and that was causing all the gases to get retained in. And then everybody went around, now she's so obese, we put her on a ventilator, we'll not be able to extubate her. So that one problem led to a whole lot of other set of problems. In addition to that, now she's in the ICU, they need to do a XYZ number of investigations, they got a echo done, they said we need to catheterize her. Somebody mentioned about a UTI. So I'm standing behind the curtains because saying we need to catheterize her, but so-and-so bed is having that infection and so-and-so bed is having that infection. So there's complete resistant infection going on in that ICU. So you can imagine, as a consumer or a patient who's right outside the ICU, we really do not know what is happening in the large number of errors which are happening in practice. There are not enough questions asked. Because there are not enough questions asked, there's not a lot of effort which is put in by the healthcare providers to improve what they're doing. Right? Nobody's asking my outcomes. Why should I bother so much? I'm anyway so busy, and I'm like up since 8 till working till 11. So there's not a lot of work that goes in. I'll show you 2 videos before I go on these slides. They're actually courtesy. I've not even seen whether there's a copyright on it, but this is from edX. I do not know if any of you do any of the Harvard edX courses. edX is the online platform. Yeah, so you might have done this. This is on improving quality in healthcare, taken by one of my professors, Ashish Jha. So without taking permission, I've downloaded it. But just to drive the point how big the problem is. So with due reference to that, it comes from there.
So today, I am very excited to have Dr. David Bates with me. Dr. Bates is the Chief of General Medicine at Brigham and Women's Hospital, where he's also the Chief Quality Officer. But the real reason we have him, beyond those very important positions he has, is that he has been the sort of pioneer in studying patient safety, health information technology, and how they intersect. Dave, thank you so much for coming.
Thanks for having me.
So I want to start off by first taking a theoretical example. Here we are at the Harvard School of Public Health. We're right across the street from Brigham and Women's Hospital. Imagine the Brigham is a typical American hospital. And I am a patient, I have some illness, and I go to the hospital. I go to the Brigham. What am I at risk at? From an adverse event, patient safety point of view, what are bad things that could happen to me if I'm at the hospital?
Well, of course, we try to do as much as we can to keep you from getting any of those bad things, but the fact is that there are a number of things that can happen. You could have an adverse drug event or be harmed by a medication.
So I'm going to just take a minute and write these down. So adverse drug event, keep going.
Yep, you could have a hospital-acquired infection.
Okay. So I'm going to call that HAI, hospital-acquired infection.
Yep, you could fall. You could develop a pressure ulcer.
Okay.
You could have a surgical complication.
Okay.
And you could have a deep venous thrombosis. Those are really the main causes of harm.
Okay, I'm going to call that DVT, deep venous thrombosis. So let's go through each of these a little bit more carefully. Adverse drug event, how do you think about it? What is an adverse drug event?
An adverse drug event is any injury that's caused by a medication.
Okay. And about how often do these occur in a typical, let's say, American or sort of Western hospital?
They happen in between 7 and 15 per 100 admissions. So infections, it's about 3 per 100 admissions.
Okay.
Fall is about 1%.
Okay.
Pressure ulcer is about 3%. Surgical complication is about 2%. You have to have surgery, obviously, to have a complication. And deep venous thrombosis is about 1%.
Okay. So none of these numbers offhand look very big, but is this a big problem?
It is a big problem. When you add them up, turns out that somewhere between 10 and 25% of patients who come to the hospital have something bad happen to them as the result of the hospitalization. What the exact number is depends a little bit on how hard you look.
Is this a uniquely American problem, David?
No, we now have studies from all over the world that show that the rate of harm is on the order of this magnitude. In most of the international studies which have come from developed countries, the rate has been about 10 in 100 admissions.
So today, I am very excited to have Dr. David Bates with me. Dr. Bates is the What if you're in a hospital in India or China? And I don't need to pick on those two countries specifically, but once you get out of the high-income countries to low and middle-income countries, does the pattern look the same, or are there broad differences?
I would say there are a couple of places in which there are substantial differences. Notably, the risk of adverse drug events is a bit lower.
It's low.
Yeah, and that's in large part because fewer medications are used in developing and transitional countries.
Got it.
Because many of the most dangerous medications are actually quite expensive. And then infections are more common.
So if you think about it from an overall profile of patient safety, it sounds like what you're saying is your risk of having an adverse event, having something bad happen in the hospital, probably no different in a low and middle income country, but maybe a little less likely to have a medication problem, adverse drug event, but maybe a little more likely to have an infection.
Exactly. And the risk of most complications is probably somewhat higher. The chance that it could be prevented is also a bit higher.
Got it.
The other broad category that we don't have on this list is birth-related injuries. And those are extremely important, especially in developing countries. You know, one of the things that happens in developing countries is that birth rates are very high, so it's something that happens a lot, and yet the resources that we have to deal with things are somewhat more limited. And both fetal and maternal mortality rates and injury rates are substantially higher in developing countries.
Got it. So this is not just about the fact that when women come into the hospital or a birthing center that they might have the normal complications of childbirth, but you're saying that in the process of care delivery, there may be new things introduced that can cause problems.
Yeah, that's part of it. I mean, part of it too is that women often come later to birthing centers. They come, after they're suffering a complication.
I'm going to take a step back and say, here we are. We've identified a set of adverse events, injuries that happen due to medical care. We've talked about it for high-income countries. We've talked about it for low and middle-income countries. Let's say we put all this together. From a population health point of view, is this a small deal? Is this a big deal?
If you put it all together, it's actually a really big deal. If you look at causes of death, it's a little uncertain what the exact numbers are, but in developed countries, this probably comes in right after cardiac issues and cancer. It's probably the third leading cause of death. So it's really a serious issue.
And there's some work that we've done together, supported by the WHO, that tried to quantify disability-adjusted life years lost, sort of how many years of life are lost. We found that about 43 million disability-adjusted life years are lost around the globe from just these kinds of events.
Exactly, and there were other things that we couldn't include, and we made very conservative estimates, I would say, throughout as to how big the magnitude of harm was.
Let's take a minute and just kind of identify what were things that you think are clinically important that we weren't able to get to.
Right, so among those were counterfeit drugs, unsafe injections,
Unsafe injections, yep.
and the other big one we already mentioned, which is the birth-related injuries.
Yep. So this is very helpful, and the main reason we couldn't get at this is really data issues. Is that fair?
Exactly. So, for example, for counterfeit drugs, some estimates are that up to half of all the medications in developing countries are not truly what they're supposed to be. Now, the exact proportion is uncertain. The benefit that people would have gotten if they were the real thing is also not clear.
Yeah.
But it's pretty clear that it's a big issue.
When we talked about adverse drug events, we were talking about giving legitimate drugs, but having problems from that. Here, the issue is even if you give the right treatment, there may be in some instances as much as half of the medications may not have the exact substance and dose that it's going to have.
Exactly. And then on unsafe injections, for example, in some parts of the world, it's routine to give a lot of injections. That's been a long-standing practice, for example, in India.
Yep.
And it was quite common to reuse needles, which obviously carries with it the risk of HIV transmission as well as hepatitis B and C.
What if you're in a hospital in India or China? And I don't need to pick on those two countries specifically, but once you get out of the high-income
Anybody can
countries.
tell what the numbers were? Yes. 10 to 25. Probably estimated to be the third leading cause of death after cardiovascular disease and cancer. In India, we don't even talk about it because nobody questions it's below the carpet. This morbid problem, how do we make this better? So that's when QI actually comes in. And Florence Nightingale is a fantastic example that way back in the 18th century, she used data. She looked at her processes and she looked at data in terms of how the process is working and also how the outcomes are. She found that the major problem when she went to Scutari Hospital in Istanbul, that's at the time of the Crimean War where the British, French and Turks were fighting against the Russians and the British soldiers were being brought over there, and she found there was a huge amount of filth, the sewers were clogged, and she and her 40 nurses cleaned up. And they counted, so that's what my cheat sheet is because I can't remember numbers. So she said we removed 215 handcarts of filth, found that on an average where 1,600 square feet should be the space given for each patient, there was only 300 to 500 square feet. They flushed the sewers 19 times and they found 2 horses, 1 cow and 4 dogs buried and they had to remove the carcasses. They counted the thousands of linen that they actually washed. And before all these reforms were brought in February 1855, the mortality rate of the soldiers was 42.7, about 43%. How much do you think it would have fallen after they brought in the reforms in March? What would have been the mortality rate in June? That same year, 4 months down the line. Any guesses? Oh, somebody Googled and checked. It's not fair. Internet. Yes, it's 2%. Astounding. So from 43%, it came down to 2%. And the most interesting thing is that when she told this to the medical officer in the military, do you think he listened to her and looked at the data and said, I believe you? No, he didn't. He said, no, our patients are different. Those who were coming were much more badly wounded. These are, relatively healthier patients. That's why they're surviving better. And then she compared her outcomes with the best military hospital in London and showed that the outcomes were better than what was happening to the patients in London. And that's the reason when she went back, she actually said that she'll make the report public. She had a one-to-one meeting with Queen Victoria, and that led on to huge reforms in terms of how healthcare was delivered in the military at that time. So it's possible to make better, but that's only if we start looking at our outcomes, start looking at our processes, start making changes to make things better. So it was on an average, mothers who were coming to the hospitals and delivering, 13 to 18% of them were dying. So out of 100 mothers delivering, 13 to 18 were dying. And the mortality in mothers who were delivering at home with midwives was actually 2%. So something was happening wrong, which was because they've come to a health asylum. Because he kept saying, there is something that we're causing harm to the patients, it's our hands. He introduced hand washing, he did a controlled trial, and he brought the mortality rate down to 2%. But nobody believed him. This was before microbes came in, and people thought it was causing it. And he died in a mental asylum at the age of 47. Just one last person. I'm not surprised if you don't know it, but as similarly as I'm saying that I've been to a room filled with doctors and healthcare providers, and most people have not been able to identify who these people are. So Dr. Ernest Codman in the early 19th century was a doctor teaching and practicing in Mass General Hospital, which is one of the Harvard hospitals. He was actually literally forced to leave because he had so much of emphasis on outcomes. And he started his own hospital, which is called the End Results Hospital. And not only did he measure his outcomes, he used to have an annual report where he used to publish his outcomes. And if I would ask, between 1911 and 1916, in the 5 years, he reported to have seen 337 patients. How many patients do you think would have had a reported adverse event that he reported himself? About 100, about 1 in 3 patients he found. There were about 123 patients. So 1 in 3 patient was having a reported or got an adverse event. So it all depends on how hard we are looking at the numbers to really pick it up. He was also ostracized a lot by the surgical community. He went on to found, he's one of the founding members of the American College of Surgery. He founded what we call the End Result Committee, which went on to be the Joint Commission for Accreditation of Healthcare Organizations. So some of the martyrs of quality improvement. So every system is perfectly designed for the results it gets. I think I've got a lot of engineers in the room, so they'll understand this much better when I show this. And how do we have a systems perspective, and how do we, knowing the kind of chaos that's there in healthcare or even in other industries, but healthcare more, because there's a lot of human contact. You can still control your machines, but when you're so much dependent on humans to provide care, the chances of errors are so much more. How can you make things better? I'll just show another video, and then I'll show a few slides, and we'll conclude with questions.
So I suppose the first question is, why should you or I care about quality improvement? I mean, to be honest, it sounds a bit boring. Something a CEO would have on her or his corporate objectives. But actually, if you dig a little deeper, it's pretty cool. Maybe more a philosophy or an attitude about how to make something better. And now that I think about it, it's really the attitude I'm looking for in my patients. The ability and desire to tweak their habits, seeing if this change improves their life, and if it does, to try and make it standard practice. You see, for my patients to make these changes requires skills, but it's also an outlook, the humility and self-awareness to say, I've got room for improvement, the ability to gather better approaches, try them on and see if they work, and then adapt them until they do. Well, if my patients can do that, I think they deserve the same from us in the healthcare business. So I suppose the next question is, if we have the attitude, how do we actually improve? How do we use QI to make care better? Well, the improvement business has been around for a while. Organizations like Toyota and Bell Labs and leaders like Walter Shewart, W. Edwards Deming and Joseph Juran polished and simplified the science of improvement. And then along came a pediatrician named Don Berwick, and he wondered if we could translate the science of building better cars or electronics to healthcare. Dr. Berwick also wondered if there were lessons about systems we could learn from the kids he saw in his clinic.
The systems thinker is a perpetually curious person who never thinks they have the whole answer, but is always willing to know what the next step to take is. If you watch a child, you'll see this happen. Children in their growth and development are innately systems thinkers. They're always trying the next thing. They're probing the material. They're listening to the noise. They're thinking about what the next thing to do is. And they're not in the job of solving problems forever. They're in the job of taking the next step. I think those are elements of what it means to be a system thinker. At the core of it is constant curiosity about a world that you will never understand fully, but you might take the next step to understand a little better.
Okay, we never dropped a vid into our vids, and Don is thoughtful, so I kind of thought it might improve our messaging. Let me know if you thought it did or didn't in our YouTube comments. Dr. Berwick went on to co-found the Institute for Healthcare Improvement, or the IHI, and started focusing on the low-hanging healthcare improvement fruit, which is mostly reducing errors. For example, in Canada, a researcher named Ross Baker led a study in 2004 that showed of 2.5 million annual hospital admissions, about 13.5% were having adverse events, with 1 in 5 of those people dying or experiencing a permanent disability. In the U.S., the Institute of Medicine estimated that 44 to 98,000 people were dying from preventable errors every year. That's up to 4 jumbo jet crashes per week. Often these are errors we know how to prevent, but as is often the case, knowing what's the right thing to do and actually doing it are 2 different things. In 2006, Berwick and his colleagues challenged hundreds of U.S. hospitals to bridge this gap. They felt strongly that some is not a number and soon is not a time, and so set the goal of saving 100,000 lives in 18 months. They started with this simple notion: every system is perfectly designed to get the results it gets. So how do you change the result? Well, you change the system that produces it. Changing the system requires change agents, and in my province we launched Health Quality Ontario. HQO and orgs like it recognize that it's tough to balance
I
proactive...
also asked that how many of you work in quality improvement in other industries? So I do not know if you notice in the video, he talked about Dr. Edward Deming and Walter Schuhart. Has anybody heard of
Yes.
these names? Oh, wonderful. So they were statisticians, physicists. They met together in the Bell Laboratory with the phone company, where they were looking into initially, when they were checking the quality of the handsets, they were saying which one works well and whichever doesn't, they will discard the defect. And then they moved from inspection to actually looking into the process on why the handsets were not being produced properly. And what they introduced is statistical process control, which revolutionized Japanese industry. So Dr. Edward Deming is considered the father of quality improvement. And Dr. Don Berwick, in the late 1980s, for the first time brought this model which had worked in other industries and tried and applied it in healthcare. He's still teaching at Harvard. He's a professor of pediatrics, and he was doing a very big community national demonstration project on improving community care of children. And he said, how do I simplify this? Anyways, it was a simple model, but how do I simplify further? Which is called his Model for Improvement. And in the last 2.5 decades, a whole lot of work has been done in addition to the 100,000 lives and the 5 million lives campaign. So I'll just give a brief overview of what is the Model for Improvement and maybe a brief overview of how we are trying to apply it to Indian hospitals so it seems more relevant to what I'm saying. Any questions from anyone? I can't go into too much detail. We don't have too much time. So do forgive me. So I think the example of the UTI is that the problem went in was a hip fracture, but the UTI got prolonged illness for a year. So the significant problems we have cannot be solved at the same level of thinking by which we created them. So the model for improvement is very simple. It's more harder to talk to doctors about it. With math background, it's easy. There are 3 questions. You need to know what you want to accomplish. B, what change can we make that will help us reach our goal? And 3, how will we know that change is an improvement? Anybody wants to say how will we know that change is an improvement? So it's very, very data oriented. Collect data on the outcomes, collect data on the processes, and you will have a whole set of changes. Some will work, some will not. So test it. So that's something which they do more in engineering, where you actually plan, carry it out, collect data and see whether that change helped improve your process or your outcomes. If it didn't, do you want to modify it? Do you want to abandon it? So will this work? Persistence is giving the wrong answer every time and hoping that somehow it will turn out to be the right one. They say that, what is the definition of insanity? Expecting different results. And if you want different outcomes, whether it's healthcare outcomes or any other outcomes that you want to improve, you definitely have to change the way we are doing things for the outcomes to change. So you'll always get what you have got if you always keep doing what you've been doing previously. I'm not going into the detail. I think these are largely management tools for healthcare professionals as seen as new, but a lot of management professionals will be very used to how systems thinking goes into place, how processes, so let me give you an example that might be better. So this is out of one of our projects in Bihar. Don't worry if you cannot read the small font. The reason why I'm showing this just talks about the complexity of the system that we are trying to improve. So we are starting and looking into improving basic outcomes in the mother and the newborn, maternal outcomes in terms of incidence of bleeding after delivery, postpartum hemorrhage, how many mothers actually got eclampsia, they got babies, how much of neonatal mortality happened, how many of the babies were born asphyxiated. So for these certain outcomes to improve, there are certain processes which are identified, which are known evidence-based best practice. We know that's the right thing to do. We know if we wash hands, the patient will not get infection. If a urine catheter is put in an aseptic as an aseptic procedure, there is no reason why a UTI should happen. So it's not that we are doing generation of new knowledge, but it's about making sure every time, every patient gets the right care. So it's more of an applied science and closing the gap between what healthcare should be and what healthcare actually is. But having said that, the processes which are listed as primary drivers are influenced by a whole lot of other factors. So I'm just showing you the slide in terms of the complexity that is present there in terms of do we even have people looking at how many of the facilities is the data actually being looked at? Are we even measuring how many UTIs happen in a month in our unit? Are we even seeing what adverse outcomes are happening? Are we measuring how the processes are performing? Are we actually having a team meeting to look at the data and try and find out what's the root cause, why this problem happened? If a PPH happened in last week, what went wrong? Did the right medicine was not given in? If it happened, was the right management not given in? And then a whole lot of other issues that come in. Do we have the right supplies to prevent it? Do we have the right skills to prevent it? So do we have the leadership engaged enough to work on it? So it may sound like a simple model, and actually when you apply it, it's very simple. But because you're working in a very complex system, you need to take all that in mind. So what quality improvement does is comes with a set of tools which help more organized thinking into the chaos that is existing in the hospitals, keeping data in mind, and all the time saying that sum is not a number, when is not a time, so you need to be bound by whatever you're doing. I'll just do few slides on data before I actually close. Can anybody tell me, I think a lot of people over here are very comfortable with data. I'm actually not very comfortable. I've left math a long time back, but anybody knows what is data for research, data for judgment, or accountability, and data for improvement? So you do summary statistics when you're doing accountability and judgment and saying who's better, you're doing a kind of a comparison. But much any other all the dashboards that you see, red, green, who's good, who's bad, do heat mapping, which district is performing the worst, which district is performing the best. Less incentive for me if I'm working in the district to show my data, if I'm going to be shown as red. So data for improvement largely is you collect just enough data, learn from your data as you're saying, do a number of sequential tests, and that data is looked as data over time. I do not know how many, has anybody heard of what is a run chart or looking at data over time? Engineering students? Yeah, okay. So yeah, so there's similar principles that which actually to healthcare is actually new. And so two things. One, I'm not going into too much detail. One, we are working at that T3 level where we are trying to close the gap. We've already generated primary research. We have got guidelines in place on what is the best thing to do. And then you have current healthcare practice and closing the gap between what evidence-based practice should be and what current practice is. And that's the space where we are working. Just to drive the point on what is data for improvement, just wanted to show you two slides. So you can get better numbers by three things. You improve the system, you distort the system, you distort the numbers. Very easy. Anybody wants to answer? If a school management tells them to a public school that unless 58% of students pass your math test and 67 pass your language arts, your school will be shut down. What will happen? They may kick out the students who they feel might not pass. Anything else? They'll pass everybody, right? So if we want to really improve the education system or the performance of the students who are working in that field or in that class, and we start using the data for punitive measures without trying to understand what is the reason why those outcomes are bad. It's usually not people, it's not individual students, it's sometimes not even individual teachers, it's more of a systemic problem. So how to have a systems perspective, look into where in the process in terms of delivery of either education or healthcare or any engineering industrial process, what is not happening right which is leading to the bad outcomes. So if something like this is done, they're distorting the system, they're distorting the numbers, right? So they say that there are stages of grief and there are stages of data grief. Anybody knows what are stages of data grief is? That there is denial. Oh my God, I don't believe the person's dead. I can't accept it. This shouldn't have happened with me. There's anger. And then there's bargaining with God. I hope this is not true. And then there's depression. And then there's sort of acceptance. So with data, there is this denial, this data is wrong, these numbers are not right, they can't be that high. There's anger, how dare you? There is anger when the numbers are shown. And then maybe there is a problem, but it's not my fault. It's all the other people who are not doing the right thing, I'm doing the right thing. And then there is kind of like depression. There is a problem, the numbers are right, maybe I'm also at fault, but there's nothing I can do about it. Before you actually transition to there is a problem, there is something that I can do to fix it. So I'm just trying to summarize a very broad, big improvement field in terms of having a very outcome-focused, data-focused approach, using data for improvement to try and understand what's the root cause, how can you support people working in the system to do better by looking at their data. So if their UTI is happening and I'm working in that unit, rather than blaming the person who was maybe past the catheter or even the example that I gave about patient being shifted from ER to CT without checking whether she's got anything that needs to be taken care of. These are all systems issues. Those processes are not in place. Or somebody getting your wrong surgery done on a wrong limb, it's because probably they didn't have a proper timeout, the labeling of the part to be operated was not there, the doctor was probably working 18 hours that day. There are a lot of system issues which lead to those problems. How can we look at what's the problem, prioritize what is the most important problem, and then fix it. So looking at decreasing a cycle time results, and this is for unit 1, 2, and 3, and you're looking at before and after result. The before and after, when you put it in a bar graph, is the same for all the 3 run charts that you see on your right side. But which out of the 3 do you think is improving? Have decreased cycle time. Before, the cycle time was about 70 minutes, or after the change that was introduced, the cycle time is 35 minutes, right? That part is clear. Then there are 3 different facilities or units which are having this cycle time. When you look at data over time, the data looks different. But if you put it on a bar graph and do before and after as an aggregate data, the data is same as the bar graph. Right? It's the same bar graph will work for all 3 of the run charts that are there. But only 1 out of the 3 facilities is actually improving. Can anybody wants to hazard a guess? How many believe in 1 and how many believe in unit 2? There's 1 person with unit 1. How many believe it's unit 2? 1 is the right answer. Can you tell why it's unit 1? I don't understand too much of math, so I'll make it simple. So run charts we normally look at, and this is what they do in other fields as well. We look at something which is called as a median. And in the median, there are certain, I'm not going into the details, there's certain data principles or rules which if applied to, it's statistically not a random incidence that the data is showing improvement. In slide 2, which we all thought there was improvement was happening before the change happened. The decline was already going on. The reason why I did show this slide was that for improvement, it's essential to see data over time. If you combine or aggregate your data, it's very hard to tell whether we are doing better from before or not, because the picture can look very different. For example, a similar kind of a bar graph. If somebody's actual enrollment is 85%, and they want to get more people enrolled, and the target is 70%, as a management consultant or anybody, do you think they're doing well, the company is doing well? Take this example, this is a hospital which is supposed to enroll more patients for their primary care clinic. Their target is that they need to get 70% of a particular population enrolled. They've got 85% enrolled. Are they doing well or they're not doing well? Apparently it would look, if you're looking at a bar graph, that they're doing well. But if I had to show you data over time, would you believe that they're doing well? They actually were doing well and then there was a drop. So the main point I'm saying is that when you're looking at data over improvement, when you look at it over time, it tells a completely different story sometimes. So there are certain principles in terms of run chart rules, and there are statistical process control charts. And improvement itself is a science, so I can't go too much into.
Often told that India does not have enough data to begin with and that it's not ready for QI yet. In 2012, Axis and iTRI brought together for the first time 6 clinical units in the country.
Showing was that we were working on a neonatal collaborative. This is some years back in 2012, working with 6 newborn care units in the country. And there were some experiences from the neonatologists who worked on it. And the project was on decreasing hospital-acquired infections, where they've got in some of them, about 20 to 30% reduction in the incidence of HAIs, and they're continuing to work on that. And also to tell that when I started this work about 4 years back, most people said, India is not ready for it, we do not have data, nobody's interested about the outcomes, why you want to do it. But there is a big growing interest in the field where people are questioning, and I think this is an opportunity where there's at least awareness created that hospitals are not that safe, and as a consumer, do raise your voice and ask how safe your healthcare is.